So welcome everyone to another session of GASN Forum Talks. My name is Matthew Sakeli, and I'm a program manager for education, research, and knowledge translation with the Regional Geriatric Program here of Eastern Ontario. Today's topic is one rep max living in older adults. And we're thrilled to have Dr. Christina Prevett join us today. So there's no debate. We have an aging demographic here in our province, in our country, and around the world. And too many of our older adults are one rep max living, meaning where the demands of their day-to-day life approach or exceed their maximum capacity. This puts them at risk for increases in pain, decreases in quality of life, injuries as a consequence of falling, and ultimately losing their independence. So that's going to be today's topic today. So I'm pleased to welcome Dr. Christina Prevett to join us today to discuss this topic. So Dr. Prevett graduated with a Master's of Physiotherapy from McMaster University in 2013 and has been a clinician for over 10 years. She completed her PhD in rehab science in 2023 at McMaster University as well. Her doctoral research investigated the utilization of high-load strength training principles for healthy aging and prevention of disability. Now, as a postdoc research fellow at the University of Alberta, she's investigating resistance training and pelvic floor dysfunction. Dr. Prevett also is the division lead for geriatrics at the Institute of Clinical Excellence, traveling around North America teaching rehab providers about evidence-informed ways to optimize care for older adults. So we're thrilled to have you, Christina, and welcome, and the floor is yours.
Great. Well, thank you all so much for having me. I'm so excited to be here. I always feel like I get to be in this really interesting space, having done my PhD in geriatrics. I have been a clinician. I've been a clinician scientist for many years, and I get to do a lot of direct knowledge translation work. And so I am super excited to be here. Thank you all so much for inviting me. And I want to talk to you all today about the concept of one rep max living. Whoop. Before I do that, kind of in the chat, I want to know what comes to mind when you hear the word old. We have a lot of predetermined thoughts that are influenced by a variety of different experiences, many for you maybe being work or family related. What are some of the things that come to your mind when you think of the word old? I start a lot of my talks this way around just doing a little bit of reflection of what we see or what we think about with our aging demographics, right? We have a big booming group of individuals over the age of 65 in Canada. Over 85 is growing exponentially. But yeah, we start seeing our older adults who are having increased care needs. As Ashley said, they're starting to slow down. Maybe we're thinking about frailty. Yes, Aaron got it. Like we're thinking about memory issues. We're thinking about chronic disease, challenges, loss of independence. Anybody who's an inpatient, you've probably only taken a person, an older adult, sock off once. Like the Jerry dust comes, right? We have a lot of these thoughts and beliefs about getting older. And as clinicians who are working with older adults, it's even more front of mind. One, because we interact with this population all the time, but we also interact with the most vulnerable, to use Tanya's word, the most vulnerable of those older adults, because we have this normal distribution of function. But what we also see is that our older adults believe those things about themselves as well, right? And so we have to kind of think about what comes to mind when we think of the word old and how those thoughts, beliefs, and understandings of getting older actually blend with or interact with the way that we treat our older adult population. And so in order to kind of have this talk about one rep max living, we have to start by talking about aging. And I love this quote. Aging is just another word for living, because everybody is getting older. You all are sitting in this room. You are all old people in training, because I want to get older. I want to be 100. I want to be a grandmother. I want to be a Gigi, a great grandmother. I want to see my kids grow older. So aging is an inevitability, but it's definitely something that we have this negative spin to, right? Many individuals dread their birthday after the age of approximately 25, right? Every time they're a year older, they kind of like have this internal like cringe moment, because we do not like the idea of getting older. And some of this is because as a culture, we have a negative age belief, right? We believe that there is nothing good about getting older and it is only bad, right? When we look at our society, we see this all the time, right? When we're looking at Hollywood, we are seeing these glam 25-year-olds that are, beautiful and youthful, and that's what we're looking for. When we're even talking about our famous individuals who are aging gracefully, like the person that comes front of mind to me is Jane Fonda. She has less wrinkles on her face than I do, right? But she's the one that we are thinking or aspiring to. And I don't know about you, but my 85-year-olds don't look like Jane Fonda does. We're seeing 20-year-olds who are getting preventative Botox. We are seeing fillers and filters and social media representations that change our appearance, that is giving us a skew towards youthfulness, because that is what we value, right? That is what we value. And that is what we are thinking about when we are kind of thinking about our own aging process, right? The anti-aging industry is a multi-billion-dollar beauty industry. We absolutely know that we spend a lot of time wanting the wisdom of someone over 50, but the youthful appearance of somebody who is 25, and we want to hold there for life, right? We see this in the workplace where individuals assume that our more veteran colleagues cannot take up new technology or not going to come with the times. They're quote unquote old school. And old school is, rooted in aging, but really has to do with a lack of knowledge translation or keeping up to date with new technologies, new research, and new areas that are coming in to healthcare, for example. And so this ageism, what it does is it translates into our patients. If you never see a person with a high amount of capacity or function who looks like you, then we start to have this internalized self-concept of what it means to get older. And Becca Levy wrote a book called Breaking the Age Code, and it's based on her research. She's a researcher out of Yale that talks about how the way that we think about aging becomes this self-fulfilling prophecy. Some of her research, for example, is that if you go in to hospital, you are more likely to recover back to baseline status if you believe more positively about aging versus negatively. If you have more positive age beliefs, that you mean aging means financial freedom, wisdom, experience, understanding, lack of filter, you don't care what people think about you anymore, like those positive age spins, then you are less likely to have a heart attack over a 5-year period, 13% versus 25% incidence for cardiovascular conditions when you have negative age beliefs. If you have a genetic predisposition to dementia, the ApoE4 genetic mutation, and you believe that getting older means losing your cognitive and physical capacities, you are 50% more likely to be diagnosed with dementia than if you do not believe that, even with a genetic predisposition. For us as rehabilitation providers, this also changes our outcome measures. Those who believe more negatively about aging see a greater decline in their timed up and go outcome measure than those that believe very positively. And this becomes this self-fulfilling prophecy, right? Where individuals believe that getting older means being more sedentary, being in pain, being slower, being more vulnerable. And so they start to act accordingly, right? They start to act accordingly where they start doing less. They start believing that they shouldn't do more. If something is an ache or a pain, it's arthritis and it's permanent and it's a disability, and they're going to have that for a long time. And it creates this understanding of aging that makes us believe that we can do less. And then subsequently, we respond by doing the actions that are going to translate into a capacity to do less. There are many reasons why our older adults start to feel like that, but we start to see this in medicine as well. There is a skewed perception of the aging experience by medical providers and I'm not just talking physicians, I'm talking our physiotherapists, occupational therapists, our support staff, where some of our words have made this worse, right? Sorry, Joanna, it's Becca Levy's Breaking the Age Code. I talk to my client, I get my clients to read this book all of the time. It's very, very approachable for our patients. When our clients start to interact with medicine, they begin to be afraid, right? We tell them you have the worst x-ray you've ever seen, right? Bone on bone, degenerative disc disease, right? We have individuals who are placed on lifting restrictions after heart surgeries and they are never lifted, right? Oh, you shouldn't be doing that. You could fall. Don't fall. Don't fall. Despite the fact that we actually see higher rates of falls in younger cohorts than some of our older adults. And then we tell our older adults, did you know 1 in 3 older adults fall each year? And I had a physiotherapist tell one of my clients, just don't fall, because if you fall, you'll be a paraplegic. And we see this happen over and over and over again, right? And so it makes sense that our clients start to feel like they can't do anything or that they shouldn't, because every time they interact with healthcare, they get told to do less, be careful, be safe. And we don't allow for dignified risk taking. We don't allow our older adults who are grown-ups, who have raised their kiddos, they have traveled the world, they have been high-end managers and CEOs and done all this incredible stuff with their life. But there is a switch that happens when they start to become a certain age where we start to take those decisions away from them. We don't allow them to accept risk, and we make decisions for them based on safety. And what happens is that becomes what they believe. And then they start to lose function. And the risk for safety from us as healthcare providers then continues to go up. And this doesn't just happen in our words. It happens in our actions. It happens in our actions. We have a professional pandemic of underdosage when it comes to our therapeutic exercise. I am coming out this talk, punching with a 1-2, talking about how we as a provider, if we are in rehabilitation, we need to be challenging our patients, right? We need to be challenging our patients. If they are doing 3 sets of 10 as their prescription and they do not require 60 to 90 seconds of rest in between those exercise sets, it is not hard enough. And we see our older adults come in walking and we give them long arc quad and adductor ball squeezes, right? We have an older adult who we get to warm up on the new step and they are going so slow, they don't even turn it on. It doesn't turn on. Do we really think that we're getting sufficient blood flow to arthritic lower extremity joints that is going to be less painful? No. And then you get them to do a CT scan and they say, oh, this hurts my knees. I was like, yeah, we have no blood flow there. You're feeling stiff. You haven't done any movement before that today, except maybe getting up from your bed, maybe going to the toilet. And then we expect that you are going to feel better and want to engage with exercise with us. Our older adults, what we look at our literature on long-term care facilities, acute care, home care, and in community, our older adults fall with dual tasking and reaction, right? They are walking forward and they either are trying to do 2 things at the same time, or they hit a slip or trip. That is how they fall. And yet our falls prevention initiative get individuals to stand in tandem for 30 seconds. I have never had a single person in my 10 years of practice who has said to me, oh, I was standing on one leg or standing in tandem for a 30-second interval and I fell over. Then I say, like, how can we reasonably think that we are changing a person's falls risk if we are not putting them under the specific conditions at which they are falling, which are dynamic? We can't throw dynamic or static solutions at dynamic problems. And so what we have is this underlying low dosed exercise that isn't driving musculoskeletal adaptation. Because the variable that matters, whether it is balance or aerobic or resistance training, is effort. And if it is not effortful, we are just breaking up sedentary time. And I'm not saying this to I am being a little bit spicy right at the very beginning of this talk, but what I mean for us to think about is reflect on, why do we tend to be conservative? Why do we not let our older adults show us what they can do? Why do we take away that risk? And it is because of our fear of harm, right? It's our fear that we are going to exacerbate something, that we're going to make something worse. But our master's athlete literature, for example, shows that our older adults who are master's athletes have higher rates of musculoskeletal pain, but lower rates of chronic disease. And I would rather treat a cranky knee than the complications of congestive heart failure. And so we have to have this epic reframe that is required in geriatrics that takes a preventative and a reactive lens to our geriatric care that is so much better done in a multidisciplinary capacity. And so we really want to think about this. In 2009, Dale Avers, she was very, very influential in the US geriatric physical therapy divisions. She wrote a white paper. And in that white paper, she called out rehab and said, too often inadequate resistance is too often seen in the clinic where 2-pound weights are commonly used and an arbitrary number of repetitions are done to perform without a quantitative baseline assessment of strength. Strengthening it without rationale or adequate stimulus is tantamount to malpractice. How do you know if you are getting a person stronger if you do not have a baseline level of strength for them? Like, how do you know that it is hard enough? And the answer is that we really don't. And so we really have to challenge this. And so if our perception is that getting older means being slow and fragile and weak, how do we think that that is going to impact the way that we are working with older adults? Right. When I first started talking about this, I remember talking about this 10 years ago at a conference in Toronto, and I got feedback saying that she has no idea what she's talking about. She has never seen my caseload. She has never been able to see this patient population. And it's because it's so ingrained. We get taught so much about safety that we don't consider that safety isn't the most important thing to our older adults. I'm going to throw another book at you. So if Matt wants to post it again on Amazon, there is a book called Being Mortal by Atul Gawande. He's the author of the Checklist Manifesto. And he talks about how our older adults are very willing to accept risk. It is us as medical providers who aren't, because they want to still go play pickleball. They want to go out and do things with their partners. Not everybody, of course, there's going to be some mismatch, but we want to start thinking about, yeah, Janine, it's such an amazing book. It literally changed who I am as a provider, talking about these end of care systems and programs that we have and how there's a mismatch between what our older adults want and what our medical system desires and how we need to come together to find a better way. And it really reinforced this message. Thank you. So I kind of want to talk about this reframe, right? I want this to be front of mind, and I want this to be reflective. And the Harvard has an implicit bias test that talks about the isms, right? And I've taken the ageism quiz, despite the fact that I know this, despite the fact that this is my PhD area, despite the fact that I teach on this all of the time, I still had some ageist beliefs. So it is very hard. And when you are working with the most vulnerable 10%, because they're the ones that need your care, it can be very easy for that internalized self-concept of that age group to occur. But I'm not ignoring aging, right? We know that aging does happen. The volume that I can give for my 20-year-old who is a marathon runner is not going to be the same as my 70-year-old marathoner. My individuals in their 80s with high levels of complex comorbidities is not going to be the same as my 25-year-old who has a sore knee, right? We're going to see differences that happen with age. So I want to acknowledge those and then go into individuals who may be one rep max living. So the areas that I want to focus on are cardiovascular system. So physiologically, what we see in our cardiovascular system with age is a decline in maximum heart rate, a decline in the efficiency and contractility of the heart, as well as an accumulation of atherosclerotic plaque, as well as an increase in vascular stiffness. What you're going to notice is not on this list, and I always have to bring it up, is that our resting heart rate should not change with age. To me, it is actually so wild that our normative data for resting heart rate is between 60 and 100. If I am sitting, resting, sleeping Sitting at a heart rate of 95, I am unwell, right? When I ask masters athletes in their 70s what their resting heart rate is, they said it's 53, right? As we get that heart rate creep, that is a sign of a deconditioned heart, not an aging heart. And so we, even in our healthcare system, like where our buoys are, does this hit clinical criteria for a chronic disease rather than how are these individuals doing in their day-to-day life? And so our rehabilitation and movement considerations is that we need to be taking vitals. And this is not too many of my providers who are in home health or our nursing staff, like they're epic at doing this. This is like me as an outpatient. I tend to work in outpatient community where I'm having people come to me. And so we want to be thinking about that. We also want to be intentional with our warm-ups, right? We need enough blood flow to the body in order for some of that stiffness to clear, right? We know that aerobic activity can be helpful for stiff and arthritic joints. So many of my clients think that they need to stretch more and it's not, they need to move more, period. And so we want to think about being intentional. Now, this can make some of these cardiovascular changes can make individuals feel afraid of moving their bodies, but our evidence and high intensity interval training across a variety of ages, stages, and comorbidities is far too strong now for us to ignore. We have hit training data in subacute stroke, cardiovascular disease, congestive heart failure, lung cancer, COPD, multimorbidity, obesity, individuals in their 80s and 90s, and the list goes on. But we do also recognize that our dehydration response and our sweating response decreases with age as well. And so individuals may be more susceptible to heat stress in some of our warmer months. So we have some considerations. When we're thinking about our musculoskeletal system, we see a decrease in our type 2 fibers. Our type 2 fibers are preferentially activated under high load, high speed, high fatigue, right? Which means that because of that, they are our fast twitch rates of force development increase exponentially with these type 2 fibers. They are the ones that we are going to try to preserve. Because of that, we need to think in our rehabilitation interventions about putting individuals under high speed, high load, high fatigue scenarios, right? So we want to be thinking about that when we're having or starting to develop our rehab plans. We see a loss of muscular size. There's a decrease in the motor units. And so many of our interventions with resistance training in an aging population is not about muscular hypertrophy so much as an increase in neuromuscular efficiency by having a higher amount of collateral sprouting of remaining motor units that transfers into an increased rate of force development. And then we see a loss of muscular strength that's 1 to 2% per year. This means that we should be also thinking about implementing not just strength work, but power work as well. So increasing the speed at which individuals are performing movements. And then finally, our neurological system, we see a decrease in long-term potentiation. Going back to my university days, synapses that fire together, wire together. So our learning pathways take a little bit longer for us to hardwire and have more ingrained. We see a decrease in executive function, an increase in processing time, and slower reaction time. What does this mean for rehab? For rehab, this means that dual task performance tends to be the area of balance that gets impaired first. Therefore, it should be prioritized in falls prevention initiatives. It is oftentimes put at the end of a person's rehab plan, but it really needs to be in the beginning. When we are thinking about reaction time, we have to think about that as a risk for falls and consider reactive and reacting stepping strategies as a way for us to improve a person's balance. And then recognize that we may need some more practice with learning new skills. It also means that sometimes us as rehabilitation providers, we need to talk less. And I say that as myself, as a very big talker, somebody who loves public speaking. Sometimes the best thing I can do, frankly, is to shut up. And so I can teach a skill. And instead of giving feedback every single time they squat or every single time they try and lift up an object off the ground, I'm going to let them figure it out, right? When I'm learning something brand new, I look a little bit like a baby deer, right? Kind of a little awkward, a little bit all over the place, but I just need repetitions of it. I don't need feedback every rep because I'm just trying to figure it out. And when we have these individuals with cognitive issues, then they're trying to figure it out in themselves, internalizing with their motor skills while they're also subsequently trying to listen to me. If they have a decrease in cognitive reserve, listening to me may take up 80% of their cognitive capacity, and then they only have 20% for learning. So we can think a lot about our communication styles, things that we have learned in the literature, like external based verbal cueing does better than internal. Don't squeeze your lats, don't squeeze your butt cheeks. Think like push your hips to the back wall. Think about sitting down to a chair, something that is external to the body, giving one cue and giving it at the end of the entire set. Things like that are going to make massive differences based on our systems. However, what we see with aging is that it is a very heterogeneous experience, right? We were just talking before, I have little kiddos at home. They are 3 and 5. And I knew those motor milestones, right? I knew when they were going to roll over. I knew roughly when they were going to start sitting independently, when they were going to be pressing to standing, when they were going to be starting to walk on their own. But we don't see this same set of parameters on the other side of the life continuum. And that is because our aging experience is really a report card of our lifestyle interventions across our entirety of our life, our environment, and our genetics. And so physical inactivity, sedentary behavior, chronic disease, and adiposity are all pro-inflammatory conditions that are accelerators to the aging process. We see a big rise in geroscience because many of our aging considerations at a cellular level, mitochondrial dysfunction, reactive oxygen species accumulation, low-grade inflammation, et cetera, are also the underlying pathophysiology to many chronic diseases. And so we're seeing this blending because of this concept. You're going to have an increase in atherosclerotic plaque accumulation earlier in your life if you are physically inactive, sedentary, have increases in adiposity versus somebody who doesn't. And this is where we blend reactive and when we are thinking about this idea, this concept, this is putting reserve into context, right? All of us in our bodies have a redundancy across our systems, right? Whether it's our heart, our lungs, et cetera. And with age, that excess in reserve starts to decrease until it hits a critical threshold. And this is really our foundation of aging, right? When individuals are using up their blood sugars, right? So our diagnosis of diabetes, right? Individuals have an increase in blood sugar flooding their system. Their pancreatic beta cells start to get fatigued. They use up that reserve. They get diagnosed with type 2 diabetes. When individuals are have genetic, maybe underlying conditions or genetic polymorphisms that are leading to an increased vulnerability to heart disease in combination with physical inactivity and sedentary behavior, then we're hitting a metabolic disease diagnosis. We are seeing that we have some individuals who are utilizing or using up this reserve very early. And we're starting to see individuals who are having occlusion-based injuries like heart attacks and strokes at 30 and 40, right? This is also the foundation of rehabilitation, right? If your body isn't strong enough to handle what you're asking it to do, it breaks down, and that breakdown is pain. If you fall and the ground reaction force of your fall is significantly larger than the tensile strength of your bone, you fracture. When you are thinking about function, when your body doesn't have the strength and capacity to complete all of its activities of daily living, you start letting go of how much you do in a day. You do less, you do less, you do less, until finally you start having conversations with families, friends, and loved ones about, can you stay independent in your home? You hit this critical threshold. And that critical threshold is what we call 1 rep max living. And so I don't know if anybody on this call has ever done a 5K race or a marathon or tried to do a 1 repetition maximum lift, which is the amount that you can do for 1 repetition, but it is exhausting. It takes a lot of energy. You cannot repeat it. You probably worked up for 12 to 16 weeks in order to attempt said 1 rep max. And many of our older adults are staying there in their day, right? When the demands of your life are at or exceeding your maximum capacity. If your older adult has to use their hands to get up from a chair, their 1 rep max in their legs is less than gravity. They cannot move their body weight against gravity. That is a problem. What happens if they break their wrist? I had a client who had MS, required a lot of assistance with her upper extremity, broke humeral head fracture. And because it was the humeral head that was the incident for the plan of care, they wouldn't let rehab come in until the sling had come off. But she was essentially in a wheelchair because of it, because she couldn't use her walker as much anymore. And so that is a really good example of when we have our older adults who cannot function. We know that our older adults have to work harder. So this was a study that was done on very healthy individuals in their 20s and very healthy individuals in their 70s. And when I mean very healthy, I mean, do not have a diagnosis of arthritis, do not have more than one risk factor for cardiovascular disease, has never been diagnosed with osteoporosis. None of my caseload basically would have been included in this study. And they got individuals to look at the relative effort of going up and down stairs and getting up from a chair. And then they slapped EMGs to look at electrical activity of the quad muscle relative to the maximum voluntary contraction. And the black bars are our older adults and the white bars are our younger folks, right? So our older adults are working harder. Going up and down stairs, you're at 50 to 60%, 80% effort for going downstairs. And that is roughly a person's 6 rep max. So what happens when you have more than 12 stairs? You stop going to the basement. If your laundry is in the basement, then you get somebody else to do it. You have a little nook of things that you nestle at the bottom of your stairs because you don't go up and down your stairs more than once because it is too tiring. And that is so many of our older adults, right? They are working really hard. And so the question that then I have is, what if returning to PLOF or previous level of function is BS? Because it's what got them there in the first place. It's what brought them into hospital. It's what brought them into having that fall. They didn't have the capacity in the first place. And so I really don't think it should be the goal, especially when individuals are this very vulnerable space and place, right? I see individuals all the time who are in this tipping point, they're one fall away. This is why we end up being very conservative in our messages, right? One injury away from losing their function for good. And it gives me this sense of urgency when I'm working with them. Now, is everybody going to listen to me? Heck no, they're not. But it definitely makes me think beyond what PLOF is and thinking about creating this network of downstream practices from acute care to inpatient rehab to home health to outpatient to fitness. And how do we get people moving along this cascade in a way that's hopefully more seamless? I know this is way more complicated than that, but how do we start thinking about these ways, right? Because what we really want to do is we want to square this curve, right? I want you to live long and die fast. I want you to maintain as much function as you want for as long as you can before you hit the end of life, right? That is the goal. That is my goal for everybody. I tell all my patients, no matter what level they're coming in with me, is that my goal for everybody is always to be able to get up and off the floor at 100. And of course, not everybody that I see is going to be having that mindset. But even me saying that, they look at me and they're like, Christina, I haven't been on the floor in 20 years. Right. But it starts this conversation about optimizing and maintaining function. And so, of course, what that is going to be, how we are going to build that capacity is using physical activity, right? We're going to try and optimize this reserve. And when I tell you that I use this chart in clinic, every time I'm working with somebody over the age of 65, heck, anytime I'm working with anybody really, I am not lying. Like I am always using this. And I am exposing my older adults in clinic to supra physiological loads, to loads that they do not expose themselves to in day-to-day life, because if they can lift 50 pounds with me, they are not worried about their day-to-day function, and their fear drives their decision-making. And so I want to expose them. And what we know is that there is no pill that you can give a person to get stronger. There is no pill that is going to improve their balance, right? And so We use the term exercise as medicine. It absolutely is. But it deserves its own pedestal as well, because there is nothing that is going to maintain your function without effort. And then we want to think, what type of exercise is going to make individuals stronger? Where we see is that our older adults tend to not get fitness forward rehabilitation practices, right? Our younger individuals get these big loads, right? They're the ones who get these big practices. But this person on the right with this big scoliotic curve that isn't going anywhere, right? She's lifting stuff at home. That isn't changing. This would be enough for many clinicians and providers to not introduce some of these concepts with them. And so we really want to be challenging this of like, who is going to benefit from this appropriately dosed, effortful, purposeful, progressive, specific strength training program, the person on the left or the person on the right? And where I would argue is that it's the person on the right. So this is kind of the concept of 1 rep max living that happens, right? We have a person that is in pain, and we do some sort of manual therapy or manipulation, right? All of our manual therapies, all of our tools in our toolbox should be short-term pain modulators. I do not believe that I have magic hands where the massage that I do to a person's back is going to change their outcome of their low back pain long-term, despite what our evidence is trying to make us like look at long-term changes and outcomes. That's a whole other soapbox for another day. But we do a little bit of mobilization. We do a little bit of manipulation. We give them some stretchy TheraBand exercises, and then we say, peace out. However, what tends to happen is that over the course of that low back pain, people did less. And they got support from people around them because their back was hurting or their knees were hurting or they were going through some sort of procedure, and they got weaker. And when they got weaker, and then all of a sudden they're like, you know what? I can go back to doing this activity now. My back is feeling pretty good. They have deconditioned all the muscles around their low back. And now they either re-injure or it's significantly more effortful from before, and it spirals, right? And individuals get more pain, so they sit down more. Their sedentary behavior weakens their muscles. Their weakened muscles make it more effortful to do tasks, so they detach and do less. And then we go around and around and around. And when we have individuals who have this weakness and deconditioning, stiffness, sarcopenia, and frailty, we give them an adductor ball squeeze. And we're like, you know what? That's going to significantly change your outcomes. And this is going to make you more resilient to your day, right? I'm being a little tongue in cheek here, but what I really want to do is reframe this, right? I had individuals in my research studies that were in their 90s who were lifting over 100 pounds by the end of the 12 weeks with me. And we can see this in clinic. I have a client right now who's in her 80s who's had multiple falls, and she is got a canvas bag full of a bunch of cans, and now she's trying to figure out how to get more than 20 pounds because she's doing 20 pounds for 3 sets of 12, and had a lot of those comorbidities, had a lot of those issues, thought that she was never going to go into her garden again. We see these stories all the time. And so where we really want to take is this fitness forward approach, right? We want to manage symptoms in order to maximize fitness, right? And so many people think when I say fitness forward that I'm talking about these total baddies who are in a gym with barbells. And it can be, right? It can be those individuals. But fitness forward can also be when a person can stand up. We choose an exercise in standing that maybe requires more guarding and more effort from us versus seated TheraX. When I have a person who's doing a warm-up, like we always joke that the new step becomes the documentation station, we get individuals doing intervals on that, right? Where we get them to progressively increase their effort and intensity while they are on that warm-up machine, right? It is trying to encourage standing, especially when their goals are to maintain their mobility and ambulatory function. Then we want to create specificity, right? We prioritize these big functional movements, right? Yes, there is need for some of our kind of typical like isolation type exercises. But in our geriatric population, we are focusing so much on function, where we want this to be our priority, right? We want our older adults to be doing these big functional movements. We want them to be loading up appropriately. And if our older adults, their goal is to get stronger, then we need to be loading higher load with lower repetitions, because that's where our evidence supports high load, low repetitions. And that is a hill that I will die on, right? This isn't it. This isn't it. And it's not going to change our person's day, right? It's not going to change their fatigue and lethargy, because we're not increasing the capacity of the system, whether that's a musculoskeletal system, the aerobic system. It's not going to change their fear, because we've never exposed them to anything like that to do a graded exposure approach, right? This reframe is super important because it allows individuals to change their lives, right? And so where we really want to prioritize is we want to think about this phenomenon, this reframing of what our older adults can do. We want to take outcome measures to build care pathways that are going to challenge our older adults. And not everybody is going to want to engage in effortful rehab with you. I totally understand that. But my older adults surprise me every single day with their capacity, and surprise themselves, right? So when we are thinking about our dosage and prescription, we need to be thinking about ensuring that we're hitting the minimal effective dose, right? 70% of a person's 1 rep max, an RPE of at least 5 to 6 out of 10 for volume accumulation. I'm going to put in that having higher loads for lower repetitions is going to desensitize an individual to some of the fear responses that we have with heavy loading that have been perpetuated and made worse with our healthcare system. And so I really want you all to be thinking about, how can I make my older adults a little bit stronger today? Or with one person, if I was going to prioritize something in sitting, can I get them to do it in standing? Can I push them just a little bit more today? And as you do that over and over and over again, it starts to change the way that they interact. It starts to change the way that you interact with them. And they really surprise you. All right. I wanted to leave time for questions. I was like right on the nose, 45 minutes. I'm really impressed with myself, not going to lie. I'm going to stop sharing here, and then we can kind of have some more conversations.
That was great, Dr. Prevett. Thank you so much. And I don't know about others, but this certainly motivated me to get to the gym tonight after work if we can. So fantastic talk. I'll open it up to the floor to questions. Please feel free to throw something in the chat or use the raise hand function to ask a question.
Thank you so much, Grace. I really appreciate that.
I'll kick it off here, Christina. How do you overcome some of the barriers that you're facing? Like, I'm sure you'll get a lot of skepticism. I'm thinking of my parents and whatnot. And if I were to ask them to go do this, my mom would laugh at me and say, absolutely not. So how do you overcome some of those barriers that are put in?
I love that question. So a couple of things. One is, I'm never going to dismiss a person's fear, and I'm going to lean into it and be asking about it, right? Why do individuals feel like they can't lift this? Where I then try and make a bridge is, I have like an exploratory conversation with my clients about things that they do every day. Most people carry their groceries. That's 20 to 25 pounds. Most people have to pick up a dog or a cat or a grandbaby. I always leverage the grandbabies, right? And they're toddlers, they're 30, 35 pounds. And so when we start to explore like the loads that people are exposing themselves to that they don't really think about, I tend to get a better transition. When I have individuals with high fear, then especially if I hit like a cap and say they're like, I don't want to lift more than this, then I'll flip to power-based movements. So our prescription for strength training, The IFSCR, the International Conference for Frailty and Sarcopenia Research Consensus Statement that came out a couple of years ago, put a minimum threshold, I love this, at 70% of a person's 1 rep max. For power-based interventions, we can lower that to 40 to 60% because, or to start with, because we were trying to leverage this speed. So then additionally, if they're like hard stopping me, I'll switch to speed-based interventions so that I'm still getting that type 2 fiber recruitment that I'm hoping to use to build their resiliency and rate of force development, while respecting that their fear is very real. And I'm not going to just say, just do it anyway.
Fair enough. Question in the chat: how do you coach cognitively impaired for RPE?
Yeah, absolutely. So there are a couple of different ways. So rating a perceived exertion, there's some pictorial representations of the amount of effort. And for some individuals, I am using their movement mechanics. So as we get into moderate to high intensity, you should be able to distinguish their level of effort by how they are moving. If they are talking to you the entire time, if they have not slowed down, if they try and do another set after 10 seconds of stopping, those are all signs that you can have that they didn't have to tell you that they are underdosing or at too low of an intensity. When individuals are hitting moderate to high intensity, they're going to stop talking to you because they're going to be focusing on their effort. They're going to see some movement deviations or some compensations that are occurring. They're going to be showing that lifting face, right? Like I do not have a pretty lifting face. Like effort. They're going to start sweating. Their heart rate is going to go up. And so in those situations, you may be relying on pictorial representations of RPE or other areas around their movement quality that can give you some insight into their intensity.
Excellent. Another question: how do you balance OP with your functional strength loading programs?
What does OP mean? Balance OP.
Tanya, maybe you can clarify.
Oh, osteoporosis. Okay,
Osteoporosis.
Okay, osteoporosis with I thought you were talking about like a parameter of your program. Okay, love this. So we have a research study done in 2019 called the Liftmore trial that took individuals with moderate to severe osteoporosis and put them on a 5x5 at 85% 1 rep max exercise program that included squatting, deadlifting, and impact related jumping chin-ups. And they saw that not only did they see an improvement in functional strength over a moderate intensity exercise group, but there was actually an improvement in their bone mineral density. It improved the femoral neck and the lumbar spine. So often in school, we get taught, oh, you have osteoporosis. Let's avoid this, this, and this. My reframe to you is that we have osteoporosis. Like we need to be prioritizing loading of the bones, right? Our muscles respond to loads, so we load them. Our bones respond to loads, so we suggest aquafit and chair yoga, which essentially unloads the bone further. So that reframe, for one, has been really powerful. However, I'm not going to take a person and 1 rep max them to 85%. So I will use a little bit of a slower introduction. My capacity for movement deviations is smaller for individuals with higher amounts of osteoporosis. I will use a top-down approach versus a bottom-up approach for bigger functional movements. So I will get individuals to put an object down before I start getting them to lift an object up, just because of how individuals learn things like a hip hinge. And I'll load maybe a bit more slowly as individuals are getting a little bit more confidence with some of these movement patterns. So I definitely do not avoid it. I definitely approach it with a certain level of intensity, but there are just certain things that are like asterisk signs that are considerations for me when I'm thinking about a loading program.
Yeah. So any other questions from the audience?
Love it.
No. I'll jump in with another question. I was mentioning yesterday we were running one of our geriatric education series, and one of the modules we do is falls and mobility, and there's similar thoughts in acute settings where there's always this avoidance of falls and mobility, especially when people are in hospital. You mentioned, Christina, that you're talking in a lot of hospitals, especially in the US. Do you see this shift in paradigm to more living with risk and incorporating that within rehab plans?
Yeah, so I could talk for an entire hour on this. Like this is something I'm super passionate about. So I ask every single time I go in and teach a course, how many people in the room have had a fall in the last year? My kids fall every day. Like, it's not every year, it's every day. They fall every day. And then our kids, they fall almost every week. And then our college age kids, they fall like every month, right? So what I actually see is that of my under 65, 40 to 60%, no matter what room I am in, have had a fall in the last year. I totally ate it this year. My dog came in front of me, like I was holding books went up. It was a disaster, right? But falling is a part of life. What we see is that it's not necessarily the fall, because in that context, the exact statistic that we use, 1 in 3 older adults fall each year, when taken across the lifespan, is actually a reduction in risk potentially compared to other cohorts, right? And so where I try and reframe this is I want to bulletproof people, not bubble wrap them, right? And so what we see is that it's not the fall, it's the capacity to withstand the fall. And that changes with age. Individuals are more likely to have years lived with disability. There's an exponential increase in disability adjusted life years for individuals over the age of 65 who have falls. Injuries it's harder for our older adults to recover capacity after a fall. But some of our recommendations are not helping that at all, right? They're not helping that at all, because what they're essentially doing is they're making it worse. They're saying, don't fall, don't move, don't take any risk. And that leads to hospital acquired muscular weakness. We have in the States, there's a lot of people who are starting to use PureWick or external catheters so that individuals never have to go to the bathroom. And that just makes them decline further from a physical function perspective. And then there's this rush to try and discharge them quickly. And then they're coming into home health, and our home health providers are saying, this person is not even medically stable. How are we coming in to do rehab? And it becomes this vicious cycle. So we need to try and block that. Is it better in the States? I would say no. No, it's not. We're battling the same problems in a different system.
Fair
Yeah.
enough. And we'll just end it here with another question in the chat. Are there resources for like-minded trainers? Any costs associated with that?
Yeah, absolutely. So I teach for the Institute of Clinical Excellence. So I offer 3 continuing education classes for rehabilitation providers through ICE. We have 2 online courses and 1 live course. The cost is $650 US for either an 8-week curriculum online or a 2-day live course. I teach mostly in the US. I would love to continue teaching in Canada. It has been harder for me to find like host sites in Canada because our network is in the States. But in that, if you go on to ptonice.com, we have a ton of resources. We have community-based workshops on brain health, heart health, arthritis, preparing for falls, and balance, where you can take the slides, slap your all's logo on it, and do community outreach to your centers, your seniors associations. We have a bi-weekly research-focused newsletter called Modern Management of the Older Adult, MMOA Digest, where we try and work on knowledge translation initiatives. We have podcast episodes. I'm on the PT on Ice podcast every couple of weeks. We have a podcast episode that releases every week that talks a lot about these principles. So we have our course curriculums, and it would be great to have you all in there, but we also do have a lot of free resources where I'm super passionate about knowledge translation, about how we really want to shrink this knowledge translation gap and really be thinking about not just knowing the research, but making it clinically applicable on Monday. And I think that is where there's a big disconnect, is that we have these research protocols that are optimized and beautiful, but then you come into these messy settings, right? And like working in the community is messy. Like, it's not perfect. I'm never going to have a person in a home health who's going to have a 3-meter corridor that isn't obstructed with cats and objects and things like that to get a perfect tug score. We need to blend those things. And so that's why I feel very fortunate that I get to do this kind of this type of learning, and I get to blend. I always say I have my research hat and it says this, and then my clinical hat said this, and this is how we blend these 2 things together. So we try and do that a lot for a lot of our free resources through the Institute of Clinical Excellence.
Excellent. Well, thank you much. Thank you very much, Dr. Prevett. This is a fabulous talk. We I thoroughly enjoyed it. I hope the audience did as well, and can take a couple pearls of wisdom to incorporate into their clinical settings as well. So thank you so much. And as I said at the top, we'll be restarting regional rounds coming back in May from the Regional Geriatric Program of Eastern Ontario. So keep your eye out for those, and we'll continue to offer educational experiences for you all. Thank
And
you.
I put my Instagram link there if anybody wants to reach out with further questions.
Perfect. Thank you so much.
So much. Have a great day.
Bye-bye, everyone.